Hi everyone, lovely to be here. I think some of the previous speakers have said, it's really nice to be in a face-to-face venue because I'm getting a bit nervous at the moment because I see, well, actually there's a lot of people here. The last time I spoke to this crowd is like probably ages ago. But thanks again. Thanks for Anne-Marie's kind words. I'm an early starter, but I'm a late finisher really, so don't worry too much about it. So really today, thank you for inviting me here. What I'm really going to talk about is an overview of the West of Scotland brain injury rehabilitation services. But it's a bit of a dry topic, but I hope you don't mind me. Anything at all, just ask me later on, okay? If that's all right. Okay, so just to maybe mention as well, even though I work in Glasgow maybe 3 days, but I also work 2 days in Irvine as well at the Douglas Gunn Rehab Centre. So just an overview of what I'm going to talk about today. So I'm maybe going to talk a little bit about what brain injury is, again, just to give us all kind of like a refresher, what rehabilitation within the context is, as well as just maybe highlight a bit about the associated kind of like a brain injury rehab services that's available in this side of the country, okay? So what is a brain injury? I think that's one question that we can ask ourselves a lot of time because all of us will actually know what it is, but I think sometimes it's a bit of a more personal question in terms of whether you're a person living with a brain injury or if you're a person supporting somebody who has a brain injury or actually working within a brain injury service kind of thing, okay? But actually, brain injury is as wide as a spectrum as you need it to be kind of thing. So some of the key defining words is whether it's an acute or a progressive condition. So acute would be sudden onset, where it can be in the instance like a traumatic brain injury, or even some instances like an acute bleed, like an acute stroke, that sort of thing, or whether it's part of a progressive condition. I've put something about condition specific because sometimes brain injuries can be isolated. So like in the case of a traumatic brain injury, but sometimes we probably need to remember as well, there are patients or people living with brain injuries who is actually part of a condition. It can be things like multiple sclerosis because their brains get affected as well. It can be for patients with cerebral palsy who has grown up with a specific in brain injury since they were young kind of thing. So it's really about what context we're talking about for that individual person living with a brain injury. And when we talk about types, obviously you can talk about the different causes for brain injury. So when we talk about brain injury, usually most research, most evidence is really in patients with traumatic brain injury. That's where a lot of the studies are involved in. So when you get a lot of the epidemiological studies and everything like that, a lot of it's around traumatic brain injury. Although there are hemorrhagic brain injuries as well, so it can be from subarachnoid hemorrhages, it can be for things like ruptures from abnormal blood vessels, that sort of thing. So it can vary as well. Hypoxic brain injury is also a big one, which is really under-recognized and under kind of like served, I would say, population-wise. There can be inflammatory brain conditions as well, so things like encephalitis, things like meningitis, a lot of the different conditions as well. Obviously, one of the key things as well is actually patients with brain tumors are also patients with brain injury as well, but obviously it's not something that when we talk about brain injury services, that doesn't really automatically come into the picture. And obviously, one of the key things as well that I'll probably need to highlight as well is this idea that actually stroke is a brain injury as well at the end of it. But obviously, with the way that services have developed within the NHS over the years, we've got this clear distinction between brain injury services versus stroke services. But actually, ultimately, what we need to really consider is that patients with stroke, at the end of the day, it is still a brain injury after all, okay? Just to give you an idea about how common brain injury is, somebody mentioned earlier that actually brain injury is under-recognized, and that is absolutely true. To give you an idea, so this is just traumatic brain injury. So this doesn't include the other kind of like a brain injury, kind of like types that I've talked about a bit earlier. But basically there was a kind of like a global incidence study. And what incidence means is, to put it simply, is any number of new cases within a specific time period, usually a year. When we talk about traumatic brain injuries within the UK, it was kind of like one of the studies showed that it's probably about 260 people out of 100,000 that would get a brain injury every year, and that's regardless of the severity of it. So it can be mild, kind of like traumatic brain injury, to moderate to severe kind of thing. But actually, to compare, this is actually quite high if you talk about stroke incidents over 2019, we're talking about maybe 244. So actually, compared to strokes, traumatic brain injuries are actually more common than strokes in Scotland. And to give you an idea as well, what you have here is two graphs. The graphs about incidents about how common brain injuries are within different age groups. And what you can see that actually with age, with increasing age is along the kind of like the horizontal axis. When you grow older, you're more likely to get a kind of like a brain injury, or the risk of getting a brain injury is higher. And actually, if you're male, which is represented by the blue line, there's actually two peaks where one is when you're older, and one is actually when you're younger, which corresponds to the 15 to 30-year-old age group, which actually may reflect some kind of like a risk-taking behavior during that time period as well. And this is mainly reflected in traumatic cases kind of thing. But essentially, out of all these kind of like cases that come on, actually quite a significant number are actually what we call moderate to severe brain injuries, where actually there are significant functional impairments that's related to it. But actually, this gives you a very brief idea about how common brain injuries are. But actually, the truth of the matter is this is just the tip of the iceberg, because the problem is these are whatever that's reported in hospitals, but actually there's probably a lot that are unreported. So even somebody simply having a mild head injury from having a fall, not really attending the emergency department, that's still considered traumatic brain injury. But then, obviously, if you're talking about brain injury as a whole, obviously those numbers exclude patients with hemorrhagic brain injuries, exclude patients with brain tumors, and all the different lots as well, kind of thing. So actually, what we're dealing with is we've got a lot of people living with brain injuries that's probably under-recognized. And having this reduced awareness just means that they're not really being able to access the services that they need. Okay, so that's the kind of the main point of it, really. Oops, sorry. So then the question next is, what is brain injury rehabilitation? I think sometimes people just throw out what this is about, but actually the question is what actually this means. And if we go back to basics, what rehabilitation means, if you go back to the World Health Organization definition, that is the kind of the term, but I'll maybe try to break it down. So essentially what it is any set of interventions or anything that can be done. This can be usually through a multidisciplinary approach for anybody who's living with a brain injury, who's experiencing disability because of that. And the key thing really is to help them to achieve and maintain optimum functioning and interaction with the external environments kind of thing. And actually what that means is that the key thing here is about allowing patients living with brain injuries to fully participate in whatever role that they are important to them. So this can be social roles, can be vocational roles. And what we do as a rehabilitation team is to try to maximize, try to empower these patients going forward to try to fulfill their best potential kind of thing. So that's the kind of key thing about it. And there are sometimes some keywords that come out from rehabilitation itself. So when we talk about, So sometimes when we talk about rehabilitation, there's this idea about physical versus cognitive. So when we talk about them, that's usually kind of like based on the different centers or the different units that get set up. So you probably sometimes you hear that there's physical rehabilitation centers, or there might be cognitive rehabilitation units kind of thing. And I think that's really got to do with how these services are set up to meet some of the needs of the clients kind of thing, because it's really about the environment, which is really important to make sure that you are able to manage some of these difficulties, which I'll kind of explain a little bit about later on. But actually, at the end of the day, what's really important is that every patient living with a brain injury does present in very, very different ways, and no one person living with a brain injury is similar to another person living with a brain injury, because when you talk about the different impairments that person is living with, it might be physical, it might be cognition, it might be cognitive. So what I mean by cognition is memory. It can be things about doing day-to-day tasks. It can be about attention, or actually whether it's also what we call the biopsychosocial kind of thing, so whether there's actually emotional disturbance from the brain injury itself. So there is a spectrum of different degrees of how a person might present, and what's really important is that for a rehabilitation unit is identifying all these different aspects of impairments, trying to find out what the patient's goals are, and working through a multidisciplinary team approach to try to target all different goals so that the patient can subsequently reintegrate back into the community kind of thing. And that's the ultimate thing that we're looking at really. And the question really then comes after is that, are there any specific guidelines about how brain injury rehabilitation can be conducted? And I think the difficulty is that there's not really a lot of information out there, unfortunately. The only guidelines that's really available is one that's kind of like written up by the SIGN guidelines that was published about maybe 10 years ago now, in 2013, which basically shows that, it's really about addressing the biopsychosocial nature of the patient's needs and trying to work from there and try to meet the goals that the patient has kind of thing. But one that actually comes up from there as well is this idea about brain injury definition. Because at the end of the day, what's really important is trying to find out how severe a brain injury is. So when you talk about traumatic brain injury itself, normally it gets split into mild, moderate to severe brain injuries, but actually, and that can give you an idea about how to triage the patients to see what they might need kind of thing, but that's not really done very well within the kind of like the medical services anyway. But there are studies that show that actually for a person living with a brain injury to be in a specialist rehabilitation unit is effective and is cost effective as well, because through these approaches, what is shown is that they're able to reintegrate better into society with less dependency. And I think there is a scope to say that actually brain injury rehabilitation is going to be an important thing for a lot of these patients going forward anyway. One thing I want to maybe touch on a bit as well is about case management as well. So case management is really important, especially once the patient actually gets away from hospital, because sometimes the difficulty is trying to negotiate and trying to find out what available services are there for the patient after they get home. And actually the problem is that at the moment in the west of Scotland, a lot of the services are not really well established, or it's a bit of unfortunately, it's a bit like a postcode lottery at the moment in terms of what services might be available. And I think it's really important that this gets kind of like a linked in from that point of view, from a case management point of view. So this is actually really important. When you talk about the west of Scotland, the first thing that comes to mind is how do you actually define it? Somebody who might be traveling to Scotland might say, oh, the west of Scotland is going to be a nice drive, nice 18-hour drive along the west of Scotland, and to see how things actually will go from there kind of thing. But actually, as you can see, it is a long drive. But actually, what's really important is how we organize things from a service point of view. And probably what's a bit more helpful is to look into how we split the west of Scotland into the different NHS, different health boards kind of thing. So technically speaking, traditionally, the Scotland has been split into north of Scotland, west of Scotland, east and southeast as well. Okay. So in the west of Scotland, normally what we talk about is this different health boards. So there's NHS Ayrshire and Arran, there's NHS Dumfries and Galloway, Greater Glasgow and Clyde, Lanarkshire, and actually part of it as well is the Argyll and Bute Health and Social Care Partnership. So that is actually within the west of Scotland as well, but it's traditionally what was the old NHS Clyde board kind of thing. But that's also under Greater Glasgow and Clyde in terms of services, really. In the more recent years, obviously there's been the establishment of the Scottish Trauma Network, and I think we've got a speaker later on to speak more about that. But essentially, just to give you an idea that when we talk about the west of Scotland as well, it comprises of this kind of like a red area, including all the different health boards that was discussed here, but also including some of the Western Isles actually. So we cover the Western Isles as well. So when we talk about what inpatient brain injuries rehabilitation services are available, there's actually quite a few different ones in the different health boards. Okay, so I work across Ayrshire and Arran and GGC, and actually in Ayrshire and Arran we have the Douglas Grant Rehabilitation Ward, which is based in Irvine. In Dumfries and Galloway, there's a small unit at D7, which is within the Dumfries and Galloway Royal Infirmary. GGC, what was formerly the PDRU, now we've been rebranded as the Neurorehabilitation Unit. So we do take patients with brain injuries as well in both our Queen Elizabeth University Hospital sites as well as Clyde Royal. And then just to maybe mention a bit, probably it's not my place, But I do work quite closely with some of the clinicians in NHS Lanarkshire, but there is an inpatient service that's being developed at the moment that hopefully will go live at some point at the end of the year anyway, okay, which is obviously a really good development from that point of view. And just to maybe mention as well that in terms of the GC units, because we're a regional service, we also take patients from the Western Isles as well as the Argyll and Bute health and social care partnerships as well. When we talk about the outpatient services, essentially, it's really about what is available in the local community in terms of like what's being established within the local health and social care partnership areas. So, for example, in Western Bartonshire, there's the brain injury service over there, kind of thing. And then obviously within GGC as well, there's the Community Treatment Center for Brain Injury. But actually, the important thing here is that there are pockets of areas within different areas that don't really have specific brain injury services, and that is a problem. And obviously, what I maybe like to mention is that actually the key thing is that sometimes it's about signposting, but there are what we call the neurorehabilitation clinics, most of these health boards anyway, and the first port of call will probably be to get a referral done to myself or any of the other rehabilitation medicine clinicians, and then we can try to signpost appropriately from there. So this is kind of like a where of things. And obviously in NHS Lanarkshire as well, they've got the community brain injury team, which is a really good kind of like a service for clients within NHS Lanarkshire. Like I said again, West of Scotland Major Trauma Centre, that's based in the Queen Elizabeth University Hospital. They do take patients with traumatic brain injuries as well, but mainly in the context of polytrauma. So they've got a really good inpatient service there as well, which we link in from our neuro rehab service too. When we talk about other brain injury rehab services, obviously there's couple of national services. So the first is Astley Ainsley Hospital, which is based in Edinburgh, which sometimes takes on patients a bit wider than within the NHS Lothian remit. There's Robert Ferguson unit as well, which they've obviously got a wee kind of like a counter there as well. We can have a chat. But usually when we do have patients who are a bit more difficult to manage or who have more specialist needs kind of thing, we will get these teams involved as well. Obviously, there are the non-NHS facilities as well, which again they've got some of the kind of they're here on the booths. So including Graham Anderson House, which is based in Springburn in Glasgow, as well as Murdiston Brain Injury Rehab Centre, which is based in Wishaw. And we do sometimes refer these patients on directly from tertiary care kind of thing. And actually, what I would probably say is that traditionally, this role about assessing patients for consideration of non-NHS facilities was previously done by Professor Tom Macmillan, as well as Claire O'Brien as well. And I think, like someone mentioned earlier, it is a great loss for in the west of Scotland that they're retiring or have retired. And actually, we've got really big shoes to fill. And obviously, what we're doing at the moment is that our neurorehabilitation service in Glasgow are doing some of the work that they've kind of like we're picking up some of the work that they left off anyway. But what I would say is that if there's a need for patients to go on to these units, mainly for a cognitive rehabilitation point of view, or with some issues with challenging behavior, then the key thing to do would be to contact the rehabilitation medicine or neurorehabilitation services in the local health boards. And that's when we actually do some of the assessments and referrals and onward referrals to see what would be the most appropriate thing for these patients anyway. And then maybe just a little bit about a subset of patients. So patients with PDOC. So PDOC basically stands for patients with prolonged disorders of consciousness or patients in a low awareness states as a result of their trauma, of their brain injuries. So they're a small group of patients, but they are a small group of patients with highly specialist needs. And actually, the key thing about these services is that a lot of these patients get referred to either the Astley Ainsley Hospital or Murdiston, mainly from the kind of the more western coast areas kind of thing. But we do take some of these patients locally within NHS Greater Glasgow as well as Lanarkshire kind of thing for assessments and ongoing kind of like a rehabilitation needs or placements and stuff like that. So just to give you an idea about that. So it's a very small group of patients, but they do exist. And actually, I think what's really important to understand as well is that, or to remind ourselves as well, is that rehabilitation don't just end at the doorstep. What's really important as well is to make sure that there's ongoing support for a lot of these patients. So it can be in the way of kind of like a community support. And actually what's really important is that it's really about signposting. And obviously the Head Injury Information Directory is a really good resource where a lot of the local information can be found for a lot of these patients with brain injury. Headway is always a good kind of like a resource for a lot of these patients as well for ongoing kind of like a community support. When we talk about financial support as well, actually this is really important as well because most of the time, especially in acute brain injuries, patients lose their jobs to a certain degree or they need more support from a vocational point of view. And actually directing them to financial support is really important. So things like Money Matters or Citizens Advice Bureaus are really a good resource to just look into negotiating the complexities of applying for different grants and stuff like that, or different benefits and stuff. But actually local charities and grants can be quite important for certain situations. And actually one really good website is actually turntous.org.uk, where you can actually try to find what are the local charities and grants that's available. If the patient needs family, because people living with brain injury are just not isolated, they've got the people extended around them as well, families and friends. And sometimes we need to remember that they have ongoing needs as well. And sometimes it's important to identify that they need support. And obviously this can be done through their local health and social care partnerships as well. Finally, the key thing is really about education, and part of it is in part self-management as well. And actually, one really good resource that has been developed over the last few years as well is the Sabin Brain Injury e-learning resource as well, which is both for patients as well as professionals. And Sabin basically just stands for the Scottish Acquired Brain Injury Network kind of thing. So you can Google it, and actually you can find some information about some of the consequences of brain injury as well, which is quite important really. So just to summarize, so brain injury rehab services are not the same everywhere in every different area. And that's a problem. I see it as a big problem. And I think it's a frustration as well. But what I want to reassure you is that if there is a need that needs to be filled, or if there's a need that any patient needs to get addressed, the key thing is always to maybe get them referred on to one of the neurorehabilitation services in that area. And actually, that's when we'll be able to assess what the patient individual needs are. And that's actually when we say that actually, you know what, this patient definitely needs some sort of rehabilitation or some sort of services input, and we'll be able to signpost appropriately where the patient can access, be it NHS, be it non-NHS really. And I think I just want to reiterate the point as well is that local community and third sector support is still paramount because at the end of the day, the interface between when we talk about health, we talk about kind of like a patient's journey across the hospital, we draw arbitrary lines. So the inpatient kind of like period, the post-acute period, the kind of like a discharge period kind of thing. But actually for a patient's point of view, it's just a seamless transition. And what we need to do is just to make sure that as a patient travels along their journey from their brain injury, we just need to support them all the way, regardless of whether we're NHS, non-NHS, and stuff like that anyway. Okay, so thank you very much. I know it's a bit of a dry topic, but hopefully that gives you a bit of an idea of what we are able to provide in the west of Scotland. But the key message is, if there's any issue, just make a referral to us, and we'll be happy to try to sort out what needs to be done for the patient anyway. Yeah.
Already before I even ask if there's any questions. So, and it's the lovely Dee. So, Dee.
Thank you for that presentation, Teng. It was really, really interesting. And while it's good to know that the rehabilitation services are out there and growing both in the mainstream and the voluntary sector, what I'm finding the more people that I speak to, you mentioned earlier signposting. And this still seems to be lagging behind for a lot of people that I speak to or that come to Headway, that they have their ABI, they're maybe in the QE or whatever, and quite often they're left without anything. I found Headway because I had a friend who used to do pro bono speech therapy for them, so I knew about it.
Yeah.
But basically, I mean, I was sort of left to leave with a very poorly photocopy of how to look out for symptoms of concussion. And that was it. And
Yeah, absolutely agree with you. Because part of the problem is that, like I mentioned, when I talk about the journey, the patient journey, and sometimes what happens is that a lot of the brain injury, kind of like a care and rehabilitation services, are usually what we call post-acute. So it happens slightly later on, but actually you're right. A lot of the input that needs to be done is actually right at the front door, right at the doorstep. Actually, especially when we talk about mild traumatic brain injuries like concussions and stuff like that, that's when a lot of patients get missed, kind of thing, because you go in to hospital, the acute kind of like a medical team thinks everything's okay, everything's hunky dory. They send you on your way, give you some advice, but actually, and that's where the problem is, because that's when things might go wrong, even though you might get signposted, but actually nobody is there to follow things up. And that is a problem. I think there are some discussions going on just now to look into formalizing a head injury pathway within Greater Glasgow and Clyde kind of thing. So that is something that I think there is some interest from the acute services, including emergency department and stuff like that. And obviously that might be something that we're looking at the moment anyway. But totally agree with you, because I think the key thing is that it's not just signposting for anyone who has a more moderate to severe brain injury, but it's actually signposting for anyone who has a brain injury, regardless of the severity, really. Yeah.
Thank you.
Thanks for a very clear overview. I thought it was worth emphasising that you're outlining services for adults with brain injury. And I just want to say that for children and young people, that there's a separate and parallel trauma pathway. And if I was outlining that, I would kind of emphasise different parts of the patient journey. But like the first questioner, I was a bit disappointed when, with the significant provision going into the MTCs, that there still wasn't specific outpatient-focused neurorehab services.
Yep.
And I think there's an assumption that the needs of children after significant brain injury can be met within child health, or CAMS, or schools. And those are obviously very important services and locations for the rehab journey, but there's still a lack of specialist-specific neurorehab expertise to guide that journey.
Yeah.
And I've, across my career, so I'm Liam Doris, I lead the paediatric neuropsychology team in Glasgow, and I think there's certainly been a lack of investment in that after the hospital journey's over, specialist outreach. So I think the major trauma developments in Glasgow are fantastic, first-rate care, and we've seen that in paediatrics too. Major resources now gone into the MTC and the Children's Hospital. But the liaison afterwards, I think, continues to be a battle that I keep fighting and keep not winning. So
Absolutely. Because I think the problem about that is that it's that situation where with the MTCs, a lot of the focus is on the front end at the moment, and actually what you say is right. Actually, what the issue is about that community reintegration, which is the most important part. Because at the end of the day, what actually a patient needs is how they actually can reintegrate back into society. When we talk about the major trauma tagline, it's saving lives, giving lives back, and I think we just need to get the giving lives back part of it well sorted, really. And I agree. I think that there's a problem with both, not just in pediatric services, but adult services as well. And the difficulty is that we do rely a lot on the community colleagues as well, just to make sure that there's this transition pathway. We also rely a lot on the third sector, voluntary sector as well, just for that. But I think that there needs to be a lot more investment in relation to that, really.
Thank you so much. Oh, another one. We're not getting away yet.
I forgot, what does MTC mean?
Major trauma centre.
Sorry, Major Trauma Centre. When I was looking at it, I was just, because my daughter was a child and now she's moving into the adult services, and Leon was a major part of Ashland's recovery. But when you're looking at it, and you just think, because you mentioned family and how we're affected as well, and it's about the lack of support for us to support the children, although at the Children's Hospital they were really, really good. But I've heard the other people, and then I'm quite empowered, but I struggled to get services, and I struggled to be a voice for Ashland because I didn't know where to go, who could help me. I wasn't getting the right benefits at the start. I'd lost my own job. I had to claim benefits while she was still in intensive care, and it was all that. And also, although I do think that the families need to recover as well, but people don't see that.
Yeah.
They just, when people meet you, they always go, and how's Aisling? How's Aisling? And it's not to be selfish, because I'm quite strong, but there is a whole, there isn't a very good ethos when it comes to once you leave the hospital, the support outside, it drops by the wayside, and if you don't know where to go, and a lot of the places have shut down. She doesn't fit into a category because she has a brain injury, but she's not classed as somebody with special needs. She doesn't bang her head off a wall, scream, shout, but she does have non-epileptic attack disorder. But she's still got an intelligence. And this is where it's very difficult to get her in, because she doesn't fit in a slot. She's nothing in common with her peers. She considers Liam Doris to be a friend and everybody for the Encephalitis Society. She's got acute amnesia and prosopagnosia. So there's loads of things that people don't know. Before I shut up, just that MTC, please be aware when you're using language that's cut down, because a lot of these are newbies.
Absolutely.
And it was years ago, my sister was at a conference, and the speaker said, if I say something that you don't understand, like MTC, just leave it with this and put it in a post-it note, and then come up at the end of my speech and put it on me. And the women ended up head to toe on post-it notes. So there you go.
Thank you very much.
Thank you for sharing that. And I think you're right. I think it's really important that we are aware of the impact that brain injury can have, not just on the patient, but everyone around them. And like I said right at the beginning as well, I think what we need to realize as well is that brain injury, the symptoms that come from it, the issues that come of it, is unique to the patient and their families. And what we need to do is really try to distangle everything out, really.
Thank you so much. If it's just a quick question, because we're just running on time.
It's maybe not a question, it's just a kind of following up. As a person that survived a stroke, when I left hospital, I can echo the comments about the support. I felt abandoned when I left. I was quite young, I think because of my age and my profession and support around my family. I felt quite abandoned, that I didn't know where to go for support, and I've kind of stumbled along trying to work out how I deal with my cognitive issues, both in a personal aspect and more so the professional. And even after 7 years, I'm still struggling to come to terms with it. And I don't really know, I still think I've got some issues that I need further support from, but I don't know where to go. So I felt as if I was forgotten about. And I think that seems to be the case in people my age group. Seems to be kind of the norm across the board, that we don't know where to go after it.
Yeah. And I'm really sorry to hear that as well, because I think the problem has been, again, is the common themes that a lot of the investment within the health services is on the front end. And a lot of the time, even when we talk about community reintegration, it can sometimes be a time-limited issue kind of thing. But yeah, I take your point. I think we have a lot of patients who struggle out there following their brain injuries, whatever it might be. And I think one of the issues is that we're not really good at picking that up, really.
That's great. Thank you so much. Could you please give a round of applause for
Thanks very much.